Thank you very much for the wonderful introduction. I hope everybody can see my slides and hear okay. I unfortunately am not able to present live in Florida due to some unforeseen circumstances, but I'm very excited to have the honor to present what every neuropathologist needs to know to share updates on the condensed protocol for neurodegenerative disorders workup. I have no relevant financial disclosures. So now just to touch on the learning objectives for this presentation. So first, I'm going to review and summarize how we perform sampling and staining to efficiently diagnose Alzheimer's disease and Lewy body disease neuropathologic change in the original 2017 publication, followed by a brief review of relevant condensed protocol publications since this time. And from here, I'll transition to describe how we have more recently performed validation for sampling and staining to efficiently and effectively diagnose FTLD-tau as well as TDP-43 proteinopathies, which incorporates both FTLD-TDP and late. So this all started back when I was a trainee, or even before I was a trainee, when in 2012, the National Institute on Aging and Alzheimer's Association recommended these minimums brain regions to be sampled and evaluated with a complex tiered immunohistochemical workup proposed for the diagnoses of Alzheimer's disease, Lewy body disease, and vascular brain injury, as well as hippocampal sclerosis. And after this was published, many people raised concerns that this was expensive, very complex, and time consuming. So during my training at the University of Washington, we aimed to specifically address these concerns regarding cost and time by proposing an alternative condensed protocol approach, which I actually presented at AAMP in 2015 in Denver. And we described how we were able to reduce sampling and material and labor costs while also maintaining the diagnostic breadth and accuracy of the original guidelines. So for this publication, from 2017, we specifically looked at 30 retrospective brain autopsy cases, which we selected to incorporate the entire disease spectrum for Alzheimer's disease and Lewy body disease neuropathologic change, as well as chronic microinfarcts and hippocampal sclerosis. And in addition, we looked at 20 prospective cases from the University of Washington's Alzheimer's Disease Research Center. So this is just to refresh everyone's memory from what the original condensed protocol was. So as you can see here, we took the approach of putting 4 smaller tissue pieces into a single cassette with a main target for each cassette highlighted in red. So for example, cerebellum, occipital cortex, specifically including the depth of the sulcus to help us assess for cerebral amyloid angiopathy, in addition to striatum and midbrain, and the thal phase here is the main target with other targets listed below. And as you can see, we have this for Braak stage, CRAD score, and Lewy body disease. So this is just reviewing how we included the entire spectrum of disease for all of these entities to comprehensively assess how this condensed protocol would perform. And as we described, it did quite well, specifically for presence or absence of Lewy body disease and Alzheimer's disease. As anticipated, it did not do as well for chronic microvascular infarcts. However, this makes sense as there's significantly less tissue area to assess microscopically, combined with the fact that we're unable to see chronic microinfarcts with our eyes at time of gross assessment. So just to summarize this publication, the condensed protocol eliminated secondary sampling and staining while exceeding the recommended minimum sampling and also reducing cost about 75%. So since this time, there have been a number of other condensed protocol publications, which I will briefly touch on. So in 2018, I was actually a co-author on this project with my co-trainee Raj at the time at the University of Washington. And over a 12-month period, we looked at we performed the sampling protocol for the condensed protocol on all individuals 65 and over, or those who had a clinical history of dementia. So 73 cases were sampled, and 72.6% had histologic findings that prompted the IHC condensed protocol workup. And what we found was that there was increased Alzheimer's disease and Lewy body disease neuropathologic change detected than what would have been expected from clinical history-driven workup alone, and that we also saved approximately $900 per autopsy case. Then in 2019, this publication came out from Claire Shepard, and this specifically suggested an alternative condensed protocol for the assessment of amyloid beta. And they provide evidence to support a further potential reduction of the regions sampled when assessing amyloid beta. And they specifically suggest for the neocortical assessment of amyloid beta looking at the inferior temporal cortex. And this is based on in vivo amyloid imaging, demonstrating that amyloid beta is most consistently found in the inferior temporal, anterior cingulate, and parietal opercular cortices. However, we just wanted to point out that this maybe would compromise the sampling to the depth of the sulcus for the occipital cortex, and perhaps wouldn't be as good for the detection of cerebral amyloid angiopathy. Regardless, they were able to validate this neuropathologically in their study, in addition to sampling the basal ganglia and midbrain regions. So then to touch on some cons to the 2017 condensed protocol. So because you get what you pay for, and we're cutting things out from a full workup, there are going to be some things that have to be compromised. And this paper here in 2021 from Nathan Clement and the Harvard group described the condensed protocol from 2017 as being cumbersome. They also describe how the small size of each piece of tissue limited the examination of the anatomy under the microscope. And they also suggested that there were perhaps redundancies in our sampling, for example, the bilateral thalamic sampling that had been included. So they specifically propose a simplified blocking protocol that instead only includes 2 pieces of tissue in each cassette, so a total of 6. And as you can see here, particularly in this beautiful, although only unilateral hippocampus here, that you can really preserve the neuroanatomy for a more comprehensive assessment. And they reported that this method was much easier to prepare, the blocking was more intuitive to remember, and as I mentioned, it better preserved the anatomic relationship. However, it does not have as many bilateral regions, which for Northwestern University and our big focus on asymmetry, I have to say that this perhaps isn't the best condensed protocol for us to apply, but they've validated this protocol by comparing it to the standard Massachusetts Alzheimer's Disease Research Center protocol in 52 brain autopsy cases. And this is perhaps, to me, the most interesting component of this publication. So they specifically assessed TDP-43, which we hadn't done previously, in these 52 cases, and 15 of them were determined to be immunoreactive for pathologic TDP-43 with their comprehensive ADRC protocol, 3 of which were described as FTLD TDP-43 and 12 described as inclusions in neurites in entorhinal cortex, amygdala, and or hippocampus in a pattern associated with Alzheimer's disease neuropathologic change. The TDP staining was performed on the block that had the hippocampus and superior frontal, and what they found was that they were able to identify TDP-43 proteinopathy in 87% of these cases. And the 2 cases that were negative, one of them did not have the amygdala or anterior entorhinal cortex available due to this not being represented in the simplified protocol. And this was one of the earliest stages that was included. And I just wanted to highlight, although I wasn't able to include it in this presentation, that there is a poster from the University of Washington group that also describes a slightly different TDP-43 condensed protocol, and that they found similar findings, and that perhaps condensed protocols may be more challenging for late cases in particular that are at the early stages. So if you have time to check that out from Caitlin Latimer and the UW group, I highly recommend. In addition, the other case only had very focal staining in the original workup with the comprehensive protocol. So then to transition into a publication from David Premier and Rebecca Fulkerth that described dementia in the forensic setting, diagnoses obtained using the condensed protocol at the Office of the Chief Medical Examiner in New York City. And as you can see here, this just outlines the distribution of diagnoses that were rendered from the condensed protocol from 2017 for the neuropathologic assessment of Alzheimer's disease and related dementias. And it picks up numerous entities that we had not examined previously. So this first report of the extensive utilization of the condensed protocol in the forensic setting for dementia described that this condensed protocol is also applicable for the diagnoses of a wide variety of diseases, including things such as non-Alzheimer's disease tauopathies, so progressive supranuclear palsy, in addition, multiple systems atrophy, in addition to Lewy body disease, and perhaps also prionopathy and other causes of dementia, such as immune-related, toxic, and metabolic, and lastly, ALS. And interestingly, they highlight that the high cerebrovascular disease burden in demented individuals specifically highlights the importance of considering vasculopathy when assessing cases neuropathologically for dementia. So now to transition into the goals of our recent validation study. So we wanted to update and modify the existing 2017 protocol to validate it for the neuropathologic diagnoses of FTLD tau, specifically progressive supranuclear palsy and corticobasal degeneration, both of which are 4R tauopathies, and Pick's disease, a 3R tauopathy. We also wanted to assess the performance of our updated modified condensed protocol for the diagnosis of TDP proteinopathies. So this included FTLD TDP and late. So this is just highlighting the breakdown for FTLD classification. And so we essentially assess tau here, 3R for PICS, 4R PSP CBD, and then here TDP-43. So I'm just going to briefly touch on some helpful diagnostic features of each of these entities. And I'm just describing, so in Pick's disease, phosphorylated tau immunohistochemistry specifically picks up PIC bodies, which are shown here in the bottom, these round, homogeneous appearing intraneuronal inclusions, in addition to also picking up tau-positive astrocytes. And specifically, you see these PIC bodies on tau IHC in the dentate gyrus and cortex. For corticobasal degeneration, you specifically see a pathognomonic tau immunoreactive lesion that's called an astrocytic plaque, shown here in the middle panel. And white matter tau immunoreactive threads are also a common feature in CBD. And lastly, in CBD, these cases tend to have agyrophilic brain disease commonly coexisting. And the sites for these tau-positive lesions for CBD include cortex, basal ganglia, and substantia nigra. For PSP, or progressive supranuclear palsy, the classic tau immunoreactive lesion seen is instead called a tufted astrocyte. I will show a higher magnification view of what this specifically looks like in an upcoming slide. And you also get globose tangles, tau-positive neurons, and the pathologic tau lesions seen in progressive supranuclear palsy tend to involve the basal ganglia, cortex, and substantia nigra. So now just to compare and contrast PSP versus CBD. both gross and microscopically. So on the left-hand side, this is just an example of a PSP case showing characteristic atrophy of the caudate and globus pallidus with some discoloration. You also very classically get an indistinct appearing dentate nucleus in the cerebellum, which you can correlate with gromous degeneration, and pallor of the nigra. In addition, I just wanted to highlight here, if you look at the tufted astrocytes in PSP here on the left versus the astrocytic plaque, one feature that I find helpful is looking at how they look more distended and kind of fatter more proximally for the tufted astrocytes, whereas the astrocytic plaques look more like more diffuse, fine appearing lesions. And then this is just an example of a globose tingle in a PSP case. And just to review quickly some of the CVD gross features, cortical atrophy may be asymmetric, and that the frontal atrophy is often greatest superiorly. And this is just highlighting the white matter threads, which can be a helpful feature for differentiating between CVD and PSP. Briefly, to show Pick's disease. So Pick's disease tends to present with a gross appearance of a very striking asymmetric atrophy pattern, affecting more so the frontal and temporal lobes of the brain, with more sparing of the parietal lobe. Here you can see the prominent asymmetric atrophy of the hippocampi. The interneuronal Pick bodies, which are these eosinophilic structures on H&E, which are strongly immunoreactive for tau, AT8, as well as ubiquitin, but less so. Pick's disease cases often have very prominent neuronal loss and gliosis, and you can also see immunoreactive tau astrocytes. So I just included this table for FTLD tau from an older paper from the legendary Dr. Dennis Dixon. And I just wanted to point out specifically that for a lot of these diagnoses, FTLD tau and FTLD TDP, we specifically do a lot of clinical correlation. And you just need to be careful and kind of take that into consideration. And I'll kind of give some advice in the last slide on how to address this in your daily practice. Now, briefly, just to summarize the subtypes of FTLD TDP, this is a really beautiful figure from a 2017 paper from Eddie Lee and his group. And I really like it because it just visually shows you, for example, type A versus or type A and type C involve superficial layers, whereas the other three types are, more extensive through the entire cortex. It also compares and contrasts the different types of lesions that you see in the cortex. So for example, type A has intranuclear inclusions, kind of more fine dystrophic neurites and neuronal cytoplasmic inclusions, whereas the dystrophic neurites in type C tend to be very characteristic, long, ropey, distended. These are some high-power photomicrographs showing type A. So you can see here that there are more neuronal cytoplasmic inclusions, as well as neuronal intranuclear inclusion, and these kind of very fine appearing dystrophic neurites. Whereas in type B, you have more granular appearing, increased numbers of neuronal cytoplasmic inclusions and less dystrophic neurites. Here showing the very characteristic long, ropey appearing TDP43 immunoreactive dystrophic neurites seen in TDP type C. And then type D is rare, but there tend to be less neuronal cytoplasmic inclusions, more intranuclear. I've just included this for people to be able to refer to, just listing here the areas for the full workup that we start with for the assessment of non-AD tauopathies. And then here just showing the areas that we start with in the ADRC with the full protocol for TDP43, plus or minus ALS. So now I will just transition to describe how we performed the sampling and staining for the validation of the neuropathologic diagnoses of FTLD tau and TDP-43 proteinopathy. So I've highlighted here just the additions to the original 2017 protocol for the assessment of these entities. So it essentially just added 3 phosphorylated TDP stains as well as some of the tau stains. So 3 neuropathologists, including myself, reviewed these comprehensive updated protocol slides to perform the validation for these diagnoses. And we compared the results from reviewing the condensed protocol slides with the gold standard Northwestern University Alzheimer's Disease Research Center original diagnoses with the full workup. And we looked at sensitivity, specificity, and positive and negative predictive values. Of note, we also collected data for coexisting Alzheimer's disease and Lewy body disease, neuropathologic change, chronic microinfarcts, and hippocampal sclerosis. And this will be included in our publication, but for the sake of time, I'm not going to talk about these particular results today. So we looked at 64 cases with the breakdown here to include cortical basal degeneration, PSP, PICS, late, and the spectrum of FTLD TDP. We had to exclude 1 case because the IHC did not work. So 63 were included for our analyses. And what we have here is showing that this condensed protocol appears to work quite well, actually, for specifically PICS disease, which is a very classic, unique-looking entity. But in addition, when we assessed presence or absence of pathologic TDP-43, that was also excellent. As expected, it wasn't as great for differentiating FTLD TDP versus late. So just some things to consider. So interestingly, CBD and PSP cases were missed by all of us, particularly in the setting of high coexisting Alzheimer's disease neuropathologic change and coexisting TDP-43 proteinopathy, which is interesting. This also raises the question, what do we call pathologic TDP in this particular setting? Is it late? Is it FTLD tau plus FTLD TDP? Is it a different name? So just some food for thought. Additionally, we found that the tau positive white matter threads, as shown on the bottom right, seem to be one of the most helpful features for differentiating cortical basal degeneration versus progressive supranuclear palsy. And then I think that if we had more clearly defined criteria for how to neuropathologically differentiate between late and FTLD, that we would have done better at differentiating between the 2 of them. But so for example, when I looked back at all of the cases, it seemed that we were very consistent about diagnosing FTLD TDP when there was only up to low coexisting Alzheimer's disease neuropathologic change. But also very interestingly, one of the cases that we all missed was specifically a case that had high ADNC with coexisting TDP that had specifically intranuclear inclusions, neuronal cytoplasmic inclusions, and fine dystrophic neurites. So we all called that late, but it turns out that the original gold standard diagnosis had called that FTLD TDP type A. So that's another great example that I think as we progress in this area that we can hopefully use and discuss to try to come up with more clear consensus diagnostic criteria. Other possibilities are I've heard that there are some newer antibodies coming out that may be able to accurately differentiate between late and FTLD. And I welcome everybody to share their thoughts. If you have any suggestions or experience as to all of these entities and even more as demonstrated by Premier et al. And I just wanted to re-emphasize that it's best, particularly if you don't have clinical information available to correlate with, specifically like an amnestic AD type of dementia, which is associated with late, versus a behavioral variant frontotemporal dementia or primary progressive aphasia, which would be more associated with FTLD TDP. If you don't have that degree of comprehensive clinical information, you may consider simply stating TDP proteinopathy, see comment. And if you're not sure at all, I recommend just deferring to that just to be safe. So our next steps are to complete the statistical analyses for the data collected for the breakdown of the FTLD TDP subtypes A through E, in addition to adding more cases from the clinical course specifically upon receiving approval to increase the N. We also would like to invite outside collaborators to assess the condensed protocol sides. And we are officially validating this protocol next for the diagnoses of multiple systems atrophy and ALS. And lastly, we would like to test this for other rare entities in our brain bank, such as globular glial tauopathy. So these are my acknowledgements. I'd like to thank the research participants for their contributions. This is our funding. Highlight those who participated the most in this project, specifically my colleague, Dr. Rudy Castellani, our trainee at Northwestern, Rachel Maltz, Eileen Biggio, who's emeritus, and then Callan and Arlene from the Neuropath Corps, who substantially contributed to this work. And then all my other collaborators listed here. And I'd like to thank my mentors, Dr. Dan Bratt and Dr. Craig Korbinski, and as well as my mentors in the Meslem Center, Bob Vassar, Marcel Meslem, and Sandy Weintraub. So that's it. And I just wanted to end, if anybody's interested in participating and collaborating, please email me. My website's here, and I'd be happy to take any questions.
Thank you, Maggie, very much. This is exactly what we needed. Excellent. We have time for a few questions. Please,
Okay.
Drew.
Hi, this is John DeWitt from the University of Vermont. I was wondering, hi, can you hear me? Hi, this is John DeWitt from the University of Vermont. I was wondering, do you use this in the general autopsy setting? Because I've found that our 6-block protocol that we developed has been really helpful in the general autopsy setting in my current practice for diagnosing anything. I've seen PSP, GGT. I was just wondering what your thoughts on that are.
So I mean, we applied the condensed protocol to the hospital autopsy setting in that 2018 paper at the University of Washington, and it worked really well. We've more recently at Northwestern started to use the condensed protocol, the modified version, on some PSP and CVD cases, but it's only been fairly recently because I've been trying to get the validation done to say for sure that it works, but I think I'm feeling pretty confident after these updated results.
Thank you. Rebecca?
Hi, Maggie. It's Rebecca Folkers from New York. Thanks for the shout out. We appreciate it. I just wanted to clarify in case people, hadn't gotten the message that for certain of these entities, you do need to put in extra tissues and extra blocks and do a couple extra stains. But sometimes you can, on the basis of the gross, if you see or if you have a history that sounds like multiple system atrophy or something, you can just supplement with some extra blocks and extra stains up front, or you can always go back to the bucket in case. So you don't really lose anything by starting with the condensed protocol, as long as you save your. So I don't want people to feel like they're constrained by those 5 sections. So that's all. I just wanted to add that little comment. And thanks so much.
Thank you. Yeah, thank you so much. And Thank you for emphasizing that. I think that's really important to take into consideration and to always keep in mind that, yes, this is, at least it could be used as a great starting point, and you can always take more sections and do a more comprehensive assessment. For example, differentiating between CBD and PSP, if you need to take some more sections, more comprehensively assess the distribution of tau, like very strongly encouraged. So thanks.
May I use one of the virtual? So there's a question here. Do you have an alternative to using a silver staining for plaques?
Yes. So at Northwestern, we actually do thioflavin S staining. So that's one alternative that's very cost effective, although you do need an immunofluorescence microscope. And in addition to that, I personally really like to look at the amyloid beta IHC and then look immediately at the tau IHC. And I think that that can be particularly helpful for differentiating between, for example, like astrocytic plaque versus a neuritic plaque in Alzheimer's disease. So those would be my specific tips.
One more question, and then we should get.
Hey, Maggie, it's Jared Aronson. Great talk. I have a feeling my comment might piggyback on Dr. Folkerth's comment a bit, but you mentioned validation for other disorders are in the works. I'm curious if your condensed protocol has any experience with CTE types of pathology.
I have not looked at that at all, but I would love to collaborate and work on that with someone who has more CTE expertise than myself.
Thank you again, Maggie. We appreciate very much the work you're doing, and I'm so glad that you were able to come by Zoom. Thank you.